All right. Good afternoon, everyone. We're going to go ahead and get started. I want to welcome everyone to our Timothy A. Johnson Medical Scholar Seminar Series. We always just take a few minutes at the beginning to remind everybody sort of the intention of this seminar series, which is something that's been going on at our medical school for a while now. It's named after Timothy A. Johnson, who was one of the founding deans at our medical school in terms of building up our medical student research program. And he was really passionate about the importance of helping medical students and then practicing physicians remember sort of the importance of research in their everyday interactions, whether they went on to be researchers or not. And so we named this seminar series in his honor, and we're always looking for speakers who embody this idea that, you know, at the same time as caring for their patients, they are appreciating the value that research and interactions with researchers brings to the improvement of health and healthcare delivery. So I'm going to turn it over to Dr. John Epling, who is professor and vice chair of research and population health in the Department of Family and Community Medicine, to introduce today's speaker.
Thanks very much, Dr. Lakhani. I have the great pleasure of introducing Dr. Chyke Doubeni. Dr. Doubeni is a clinical epidemiologist, a practicing family physician, and professor of family and community medicine at the Ohio State University. I'm supposed to say that right now. He serves as director for the Center for Health Equity at Ohio State University and as the chief equity officer for the OSU Wexner Medical Center. He is also associate director for diversity, equity, and inclusion for the OSU Comprehensive Cancer Center. His research concerns the effectiveness and delivery of cancer screening with a primary focus on colorectal cancer and a particular interest in addressing inequalities in delivery and outcomes across the care continuum. He's helped demonstrate how coordinated, uniform delivery of evidence-based care across the continuum of screening can eliminate colorectal cancer health disparities. He's published well over 200 journal articles, regularly updates author topics on UpToDate. Previously, he served as the section editor for DEI and as associate editor for Gastroenterology, the premier GI journal. So that's a family physician as an editor for a GI journal. Dr. Doubeni is a recipient of the Presidential Early Career Award for Scientists and Engineers under the Obama administration. I saw pictures of this and it was very cool. Pictures of you receiving that award in the White House. Very, very neat. He currently serves on the National Cancer Institute Board of Scientific Advisors and co-chairs the National Cancer Advisory Board's ad hoc working group on strategic approaches and opportunities for research on cancer among racial and ethnic minorities and underserved populations. Dr. Doubeni and I served together on the U.S. Preventive Services Task Force, and he chaired its Race and Racism Work Group to transform the recommendation development process through a health equity framework. This work culminated in a JAMA viewpoint on behalf of the U.S. Preventive Services Task Force in January 2021 that included the following commitment to change the methods of the USPSTF going forward. And I quote, "The development of recommendations on clinical preventive services must therefore be inclusive and more fully consider the effects of social, economic, and structural contexts in which disease and related sequelae occur. This requires an intentional focus on embedding health equity into every step of the recommendation development process to ensure alignment with the needs of populations adversely affected by systemic racism." It is my great pleasure to introduce my friend and colleague, Dr. Chyke Doubeni.
Thank you, John, for that kind invitation. And it's really exciting to be here. I come to Virginia often, but it's my first chance to be in Roanoke. Perhaps it's my last till today, but thank you again for having me. In the interest of time, I'm going to just dive in. And if you have a burning question, please raise your hand and ask so we can share together. What I'm going to do, and it's great that you had a chance to peek at some of the work that we've done over the years, is to try to walk you through, and I think appropriate to the questions that were asked earlier in a lunch meeting, the journey that I took with colleagues on this work. And these seem to be on autopilot, so there may be a little bit of a delay in some of them. Because when I began in research, as many of you I hope will do, the question is, what do you do? And what do you do after what you do? And how do you see the impact of the work? Research is one of those areas in which we spend a lot of time doing many things. And sometimes there's a lot of grind involved. There's only a timer, so it's going to be a little challenging to see. And ultimately, I settled on colorectal cancer as the condition that I studied. And colorectal cancer ended up being a perfect condition for much of what I was interested in. And these are the reasons why. So we talked about why do you do a screening test? And for colorectal cancer, we happen to know with a high degree of confidence how many of those cancers form, right? What is a precursor solution from a normal colon mucosa to one in which there's perhaps mild dysplasia and the severe dysplasia and then to cancer. Even for cancer, there's an early cancer, then there's sort of metastatic cancer, which is more disseminated and more difficult to treat. What I like this slide for, it's an old slide from 2004. The reason I like it is that you also see the markers as it develops, right? As they show up in the system as cancer becomes more and more advanced. And if you've heard about multi-cancer detection and why the markers have been used, you can have a sense of where you will find these markers and what stage of cancer development you find the markers. So this has been, in many ways, a good way to look at colon cancer. But ultimately, the reason why we do any cancer control work, disease control work, is to prevent disease, or we detect it early and treat it. And the reason why we treat is to minimize the effects of disease or to cure it. And for colorectal cancer, matching this biological concept that you see here to that disease control concept is important. And I like this framework from the Community Guide for Preventive Services, which is a sister partners, task force to the U.S. Preventive Services Task Force. They talk about increasing demand, increasing access, and improving delivery. And we'll come back to some of this concept. What I want to plant here as we go through this presentation is think about this as a multi-layered process. All right, so you imagine a patient who is coming to see you when you're in the clinical years. So get screened for colorectal cancer. Well, who should be screened for colorectal cancer? Like me, right? When you get to the right age. What would it take to get the person to get screened? What needs to be done afterwards? And what are the factors that make it possible for the person to get screened? What are those things that make it harder for the person to get screened? How do you address them? And we look at this as a multi-level concept. You'll hear me say it now if I forget to say it later. Think of the system first, right? Because you have to have a system in place for people to be able to get this service. So think of the system first. But of real interest to me is the ideal that our care needs to be inclusive. Our research needs to be inclusive if we're going to be able to find solutions for the majority of Americans and ensure that the benefits of discovery get to everyone. So in essence, that's my presentation. But let's go on the journey. Why is this important, right? So that's a picture of the colon and a few things around it, liver. But let's focus on the colon. So this year, it's estimated that about 153,000 people, men and women, will be diagnosed with colorectal cancer. and about 53,000 people will die of the disease. That makes colorectal cancer the second commonest cause of death from cancer. But as I've discussed already, it's preventable, it's curable. But doing so means that we have to be able to detect the cancer at an early enough stage or precursor stage. So you saw that figure earlier. So what we're going to do is to walk through how you do so and some of the steps or pitfalls along the way. What has also been an illuminating thing for me and for many of us in this area is that despite knowing all of these things, there are a lot of inequities in the process by which colon cancer is detected, treated, and people are followed up. So how do we address those? So I think someone asked me, why did I pick this? Some of it is serendipity, so I wouldn't lie about that. It wasn't like I knew all of these things before I picked it. So it's happenstance. But what I discovered that this is actually a prototype of a disease, a model disease, in which you can understand the drivers of inequities, in which you can actually use it, in my view, and I'm partial about it, I will admit, you can use a disease to actually help you understand what in our systems don't work right? Because if it works right, you should not have any preventable deaths, but nothing is ever perfect. So John talked about some of the work we did in the U.S. Preventive Services Task Force, the viewpoint to the left and the recommendation statement to the right. And the question about disparities versus inequities is always a debate. Disparities just describe a difference. Inequities are the connotation of fairness and justice, of being just and fair. And that has to do with, do we provide a service in a way that people can actually have access to them when they need it and how they need it? Or are there systemic barriers in place that prevent them from getting the service? So I want you to kind of think about these two papers, and I think you read one of them. And we'll come back to it in a minute. So why is this important? I have two pictures that I want to share with you. When I look at this, I look at it like a step ladder, right? But this is what I want you to do. For each of these groups, one is incidence and the other one is death. For each of these groups, just imagine for a minute to draw a line across the highest bar and ask yourself, why is that gap? And why does that gap look the same in terms of structural relationship on the left as it is on the right in terms of incidence and mortality? Right, remember I said colorectal cancer is preventable for many people. Not every disease you can prevent, but a lot of them are preventable. Why is that difference? So in a perfect world, we have a straight line across all of them, everybody. So if you stratify by socioeconomic status, you see the same ladder. And this has nothing to do with race when you look at it in that way. All right, I'm being forced to move on, so I'm going to move on. So this is a map that I love to show. And it's an exercise. Let's imagine where Virginia is in this map. It's not very hard to. But where those red dots are the Appalachia and River Delta, Mississippi River Delta area. Right? That's an area in which there's a higher concentration of, or higher incidence of mortality from both cancer and colorectal cancer. And remember that there are many more deaths from cancer than there are from colorectal cancer. So the fact that these two things superimpose should tell us that there are drivers that are not related to cancer per se. And I'll tell you that if you put a map here of socioeconomic status, you see the same picture. Put it of heart disease, you may see similar picture. Many preventable conditions will have the same pattern. So place matters. Now let's go forward. So to address this, in our group back in 2004, when I moved from practice to finish my residency in preventive medicine to work in this area, we came up with a conceptual model, and this is actually one in which we published as a viewpoint. And this was making the case as to why Medicare was not covering for colonoscopy fully when a polyp is found or a biopsy is taken. But this is actually the model that we've used to inform our research. And in much of the grants that I've written over the past 15 years as something similar to this in that. They have different elements to it. But it's to at least to show you that it's really good to have a roadmap of what you want to do and how you want to do it. What's the destination for this journey? There are one-off things that I've done. If you look at my CV, you see lots of things that are one-offs: tobacco, hypertension, heart disease, integrated behavioral health, community engaged research. I see some connections between them, but you have to have some way in which you're looking at what you're doing. At least that's been motivating for me. And the picture here is that screening for people who are eligible, and these are all important. Leads to detection of precancerous lesions or early cancers for which you can treat, and then that will reduce mortality risk. And if you do this comparably across all groups, you should be able to eliminate disparities, if not inequities. So this framework has been the way that we've shaped the work we've done over time. And as I walk you through it, it's an exciting journey, but if you look at this, we had to do studies of different designs. And all questions have their own design that you may need to apply to it. We've done observational studies, done studies with existing survey data. I recall that we use Medicare Current Beneficiary Survey, the NIH AARP study, EHR data a lot of the times. We've done clinical trials and sometimes policy statements, each of these to help answer a question that we had to fill a gap. And sometimes we're fortunate because we work with those who are actually implementing programs, and we ask ourselves, why is this so? And we try to answer it. Or the policymakers will come to us, like ACS came and said, we need to convince Medicare to change the rule, but we need this evidence gap. And so we did a modeling study to answer the question, what if Medicare paid for this? What will be the cost to Medicare? And having the right collaborators and mentors is really important. Anyway, the most exciting thing that I've done in my life is this study. It's a small study, but the reason why I'm excited about this is that despite all this work, you can do all of it and you may not be able to demonstrate that you got into the promised land. I'm not quite there yet, but it came close. So this is a study in which we use data from Kaiser Permanente in Northern California to ask the question. They've implemented this program over 20 years or so now. 2006-07 is when they started. And over this time period, can we demonstrate whether there's been any change in the gap between Black and white people? We actually have data for many other things, but this is what we picked to publish. And we'll probably end up writing the rest of this story in short order. But the picture here shows you the percent of people 25 years and older in the census tract who do not have a high school diploma. And you see that there's a clear difference between Black people and white people in terms of distribution of this risk. The point here is that people often say Kaiser is always different. So why do a study in Kaiser, right? They always pick people who are employed. Guess what? If you look at our hospitals, think about those who are in EV, environmental services. What we found is that some of them have to work multiple jobs, food insecure, sometimes homeless, right? And some of the work we're trying to do is figure out how do we support our own employees. So some of this work is actually closer to us than we think it might be. And so this is in essence what we're finding in Kaiser Permanente. And so when Kaiser rolled out this program, you see that the orange line is for Black people, and the solid one is white. And the difference flipped. And you will find it interesting when we look at actually the rates of disease over time. But what's also impressive here is the rate of screening. It's very high by any measure for any other groups. So the difference itself is not that important at some point when the level is so high. So these to me are sort of the pivotal graphs. And in the interest of time, I'll go, I think you've all seen this paper, so I'll go quickly through it. So let's focus on the bottom two graphs. So you also see a paper from New England Journal, the most recent paper on colonoscopy, where you see this pattern. When you begin to insert an intervention, the incidence, especially for cancer, will go up in the group you're intervening because you're picking up cancers that are prevalent, also indolent cancers. Over time, the incidence in the group in which you're intervening should go down, and that's demonstration of effectiveness. And you see that very, very clearly. So Black people, the incidence goes way up. The incidence in white people also went up when the program went into effect. That's a vertical line there. But the increase in incidence, you can see, is much higher among Black people. But as you see, as I follow this over the years, as the program continued, and there's a lot more to this program that's important to keep in mind, that gap began to close. And you see that's very clearly actually in this lower, sorry, top right one there. In late stage cancer, those are the ones that kill, right? The early ones in theory should never kill anybody. So this is impressive, reassuring that if you do the right things for everybody at the right time, there is no reason to think that there should be a gap. This is a different view of the same thing. If you like numbers better, you see the numbers here. So in 2009, the difference in incidence was 20% essentially. Go to 2019, the difference was 6%. It wasn't significant anymore. This is large numbers of people, so that really is not, there's no difference there. For mortality, it's about the same for relative risk difference. Right, but the absolute risk difference is very small, right? Absolute difference is very small. So I find this really exciting. But to get here, and part of the journey that I described earlier is we need to know there's an effective screening test, right? You need to know you can deliver it effectively, because no use getting effective treatment if people can't get access to it, right? But the quality of care is terribly important. Even if you deliver the same care to people and the quality differs, the outcomes are still going to be different. But after you do all of this, sometimes you still have policy barriers. And some of the work Jen and I have done is addressing some of those policy barriers. Right. And so we'll talk some about those, time permitting. So this is a good graph. So if anyone knows here about CISNET modeling? Okay. So modeling is simulation. You know, it's to get simulate a population, put in parameters, and say, what if we did this and what would you get? So CISNET's modeling group, MISCAN in particular, which is out of Erasmus Medical Center in Netherlands, does a lot of this work, even for the task force. And so these are the sensitivities and specificities for what they input into the model. These are important. But what is important is that when you actually test, forget about guaiac, FOBT to the left. When you compare these other 4 ones to each other, the outcomes appear to be comparable. The interval in which you screen tends to be a little different. So in the studies we've done, and I think someone asked about why the left side is different than the right. In the studies we've done, this is one study in which we looked at the effectiveness of colonoscopy overall on the right and left side. You find there's a small difference in the relative risk reduction. So let me try to interpret this. So if you look at these red numbers to the top, out of the 5,207 patients in a case control study, in which we compared those who had received colonoscopy to those who had not received colonoscopy in terms of their risk of dying from colorectal cancer. Overall, colonoscopy reduced the risk of dying from colorectal cancer by 67%. If you look at the right side of the colon, on the right side, which is furthest from the anus, that reduction was about 65%. We look at the left side, which is the side closest and easiest to get at, that risk reduction was higher, 75%. Right? So in other words, there's no difference between the two, because if you compare those intervals, the 0.18 to 6.5 and the 1.2 to 5.3, you see that if you draw those lines on a graph, they kind of overlap. So technically, there's no difference between the two, but you can see qualitatively there's a difference in there. So the second one to the bottom asks the question, because we made a recommendation that said, okay, do sigmoidoscopy and then you do fecal testing, and doing so could perhaps augment it. But what we know is this: sigmoidoscopy and fecal testing both actually work much better on the left side and the right side. So if you use this test that actually work better in the same side of the colon, maybe they don't add much, and that's what this showed. Right. So if you had sigmoidoscopy, then you added fecal testing. This was at least one fecal test. There was no statistically significant difference in the risk of dying from colorectal cancer, either on the right or on the left. As a matter of fact, on the right, you see that the estimate was 1.02, which is essentially null. And so that's in principle kind of confirmed that suspicion that this may not be an effective strategy. That said, we do not test the strategy of repeating it every year, right? And so that may pick up other things. This is not one of our studies, but published recently in New England Journal. And this was out of Scandinavia. They looked at whether or not inviting people to get colonoscopy was effective. So this is invitation, as opposed to having people who are willing and randomizing them to getting colonoscopy or not. And that invitation, this showed that it can reduce the incidence, as you see on the curves to the left, but mortality reduction was not observed. That said, when they looked at the group who actually went for colonoscopy, they found a reduction in the risk of dying from colorectal cancer that was similar to what we had actually documented in our case control studies. So for us, it was reassuring that we're doing the right things. So having shown that the test is effective, what do you do with it? You have to get it to people. And in the interest of time, this is a nice graphic that was done by a colleague of mine who works with us. He's at Lausanne, Switzerland, Lake Geneva area. And he and Clara are doing a full-on paper to this. So look at this as a cascade of things you can do to get colon cancer screening to people. But hold your thought for a moment and let me share something with you. So how many people come to see a doctor? And when they come to see a doctor, how many of them will get a chance to actually get a colon cancer screening done? The drop-off is very rapid. If we're going to be effective in reaching people, we have to get the people, irrespective of whether they actually come for care with a doctor. This is what this program does. So let's imagine you're going to do a project. You take the panel of patients of one of your primary care practices. You don't care whether they're coming to see a doctor or not. And you mail the test, fecal immunochemical test, to all of them with an invitation to get it screened, get them to do it. If they don't respond, you call them to remind them. If they don't respond, you still remind them. When it doesn't work, then you send it to the practice where they belong and tell them that these patients haven't responded. We want you to actually call them from your office. If they still don't respond and they show up on appointments, you say, oh, by the way, we did this, you haven't done it. Can we offer it to you? Or would you like to have a colonoscopy? And when they've done the test and it's positive, this gets sent to the GI department immediately, and GI department tracks this to make sure it's completed. And if it's not done, someone is watching somewhere to see why this is not happening. So they developed at first a system they called a prompt. I can't remember what that acronym stands for, but it's a hovering system over the EHR that tracked what was happening, sent reminders, made robocalls, live calls, in-person reminders. If they showed up at a pharmacy, someone handed a kit to them. Michael Potter at UCSF did one of the studies in which he paired it with flu shots, became the Flu Fits program. All of that was done in Kaiser Permanente. So in this, we looked at sort of the response rates. What I do want you to, in other words, we followed people over time to see if we mail them a kit, will they return it? If they returned it, will they respond the second time we mail a kit to them? And the third time? And just focus on the numbers in red. Even in this very good system in Kaiser Permanente, only 48% of people responded to the first round of mailing. And remember, I talked about reminders, in which, despite all of that, only 48%. But the trick of this is that doing it over time, that 48% begins to increase and increase. And you see that when they went back to the second round, 75% of those people who responded the first time will respond. And 83% will respond the second time, and 86%. So in other words, if you keep at it, and they identify the barriers as you find them and you address them, in other words, iterates, refine your program. What messaging are you using? Is it working for this group? If it's not working, what they did was, oh, Hispanic people are not responding to our mailing. Let's get a focus group. Then they design messaging for that group. And that's what it did. Right. And so if you stratify your data to understand why a group is not responding, you can then focus the interventions on the group. What is also really important to see here is that 75 to 80% of people who were positive got their colonoscopy done within a decent period of time. So this is essentially what I was talking about. This is a graph I'm still working on. The bottom part is those who were actually up to date at the time. So imagine if 40-something% were up to date at that time, plus those who get mailed, and this is the one above that line. The automated process, the response rate you see as that darker, slightly darker shade of grayish blue. And you see that for Asian people, their response rate to that automated process was quite high, right? But for those who had this rescue or recovery piece, you see that sort of paler color over there. But the two combined strategies were needed to actually achieve those higher rates of response. And for Asian people, it's about 50%, others were slightly lower. So the lesson from this is that it takes more than just a single silver bullet to get people to respond to something. And we have to have multiple strategies that are sort of built on each other to get that response. And when you do so, you have to have the system in place, right, to support them through it. So we tested this in West Philadelphia in federally qualified health centers. This is a study in which we looked at given choice. Siobhan Mehta, a mentee of mine, he did this. One is colonoscopy only. You get them sequential choice. In this case, you give them colonoscopy. They refuse, give them FIT, or you give them an active choice. So we have two tests. We'd like to offer you one or the other. Which one would you like? It seems giving people an active choice was better. What we didn't test though is to offer them FIT, and if they refuse, offer them colonoscopy. Maybe we would have found a different result similar to that one. What we've also found is that if you set it as default, say, I'm going to offer you screening, versus we try to make that as something that we remember to do afterwards, it works better. Okay. So when you do something, we're very good at doing a lot of things, but what we're not often good at is to see what happened from what we did, or evaluation. Right? Are you still up with me on the journey? Okay. So you found that the test is effective. You design a way to deliver it effectively. And you're going to ask the question, is it getting what we wanted it to do? And in this case, Kaiser was interested in reducing the death rate from colorectal cancer. That's what this showed. So over time, compared to this year registry numbers, there was a steady decrease. And this actually was a prelude to the paper that I presented earlier on the racial comparison on incidence and mortality. So the red line is the one that shows the screening rate, and the blue line is the one that shows the mortality rates in Kaiser Permanente in Northern California. So it's good to see that, right? That your rates are coming down. And we had other evidence to demonstrate that. But then we realized there's something in between, because credit to Doug Crowley for leading this study. This is a study that ended up changing the guidelines for adenoma detection rates. So adenomas, the earlier precursor lesions to colon cancer. So the theory, at least the earlier papers, showed that if you took out adenomas or polyps, then you prevent colorectal cancer. But what if everybody's not as good in detecting those polyps, right? So if your colonoscopy is not seeing as many polyps as they should see, then you're going to get either missed cancers that occur shortly after you've had the colonoscopy, or ones that occur in the interval between what is apparently a negative colonoscopy and the next time you're due to get screened. Those are called interval cancers. We now call them post-colonoscopy colorectal cancers. So what this study basically showed is this, that the number of adenomas or polyps, precancerous polyps that it detects, that a physician who is doing endoscopy detects during colonoscopy is correlated with the risk of getting the cancer before the next time the screening is due. Or a different way to state it is that the higher the quality as measured by this indicator, the better the outcomes, or lower your risk of dying. What is different about this study than a Polish study that is a study done in Poland that had come before this was that we were able to demonstrate, because of the numbers, by advanced stage, you see the line going down, by fatal cancers or death from colorectal cancer. So out of this came the thresholds change in terms of what is the ideal number of polyps, percent of people with polyps that should be detected when you're doing a screening colonoscopy program. So those are baked in now in the endoscopy programs across the country. All right, so this is a study that was led by Stacy Federa, who is now at Emory. She used to be at American Cancer Society. And we took the same concept and said, is there a racial difference in this, right? We could have looked at socioeconomic status. We would have found the same thing. I find this interesting, and I get questions about this all the time. So let me try to walk you through it, but orient you. The red one is black. Let's stick with white and just look at the red one, right? So remember the adenoma detection rate. This was polyp, but keep the same framework. Q1 means is the lowest, is the highest quality actually. No, sorry, Q1 is the lowest quality. Q4 is the highest quality. If the line is to the right of that dotted line, it means there's a difference between black and white people. Let me put the numbers there so you can see it. So what this shows in essence is that this number here, the lowest one, is overall. And what it also showed for us was that Black people were more likely to get their colonoscopies from physicians who were lower performing. And what this shows is that when you look at people who are getting colonoscopies from the highest performing physicians, the disparity was largest. The way I interpret this is to say when there's an opportunity to make the biggest difference in prevention, you find disparities. If you have metastatic disease, for instance, everybody has a poor prognosis. You're not going to find a difference. If you have early cancers, when there's an opportunity to get the best surgery possible, the quality begins to show up. All right. You guys are still with me? Okay. All right. So I'm going to try and finish soon enough so we can have time for questions. So we talked about delays in time to testing. This is actually about where people get testing. So the lowest line, which means it's the poorest performing, is Parkland, Dallas. It's a federally qualified or similar system. In other words, in people receiving care in this system, they had lower rates of follow-up colonoscopy after a fecal test was positive. Plus, compared to the Kaiser Permanentes that you see higher up. So in a resource poor settings as rural areas of federally qualified health centers, this is a problem. This is a paper similarly we did looking at colonoscopy quality. I'm sorry, time to colonoscopy after fecal tests. In this one, you see that in the 10 to 15 year interval, you see an increase in the late stage cancers occurring. In other words, if your fecal test was positive today and you don't get your colonoscopy done soon enough, delayed 10 months. What we've actually done in modeling is almost a linear pattern, but that's what modeling shows, that the risk of dying is higher. So this is the way I have come to understand it. Why do a screening test if you cannot get the person who is positive to get the diagnosis follow-up testing that's needed? If we don't do so, and they get the cancers, you build more distress. That's my dumbed down version of this. So I like this one because it's fun. This is, I think, what you saw in the paper I shared. So if you look at it, we decided to break this down into the various steps in the screening process, because it's good to be able to look at them, but in one integrated data system. And what you see here is that 7, right? That 7 number is actually the most conservative we could derive. That if you had an abnormal test and it didn't follow up, your risk of dying was 7-fold higher than those who followed up. So again, why do a test? And when positive, there's no pathway to getting that follow-up testing and care. But yet, you saw in the earlier graph that that's what many people in federally qualified health centers experience, right? So if you look back to those pictures that you saw in the map, it's no surprise that you have that picture, because a lot of those are in rural Appalachia, Mississippi Delta area, or Alaska. All right, racing through this. In 2001, the task force did 2 things. One was to, I need a mouse click in a minute. Does this work? Doesn't work yet, but that's okay. Which was to change the age to initiate screening to 45. And that was because the task force was concerned about the issues of the disparities in certain population, specifically Black people. And these are some of the statements that we crafted in that recommendation statement. Right, I pause for a minute. So positive results on stool-based screening tests require follow-up with colonoscopy for the screening benefits to be achieved. And you see the piece about disparities. This is why it's important. So last year, the Department of Labor, Health and Human Services, the Treasury, published an FAQ, what I call an FAQ, which is essentially saying do it, the FAQ, saying that private insurance plans must cover follow-up colonoscopy after a positive non-invasive stool test. And this cited some of that language. But what you see here was the CMS guidance on similar topic in which CMS says there are two things that I find really interesting. One is that expand the regulatory definition of screening, right, to include follow-on screening colonoscopy after a Medicare-covered non-invasive stool-based colorectal cancer test. In other words, you are not screened until you have that follow-on test after a non-colonoscopy test. Right? And the second one is that when stool-based tests revealed, that's the task force language. Verbatim was copied to support this. And I can tell you that John and I we all worked to craft this language in there. This is CMS timeline for the polyp piece of this change in coverage. And so by 2030, if this stays, it'll phase out the coinsurance to 100% payment by CMS. And this also provides that all steps in the screening process must be covered, including pathology fees, anesthesia fees, all of that. So no longer is a colonoscopy code diagnostic. It's a follow-on screening test. I said what was said always, there's a two-tier screening process. The fecal test, if it's positive, colonoscopy. So this was actually the conclusion that we drew in the New England Journal paper. This sounds familiar. But I think what's also important is demonstrating the feasibility. We're not the only ones who've done that. Even Dallas, Samir Gupta and others have demonstrated that you can actually do this and do it successfully. People mailing kits out of people, right? You can do it. Or inviting people to come screen. But you have to have navigators, people to remind, people to kind of track the system. It has to be done with electronic support because otherwise it becomes really labor intensive. And human beings are very, if you're like me, very prone to error, right? So we need that sort of robotic support in the background to make things work. But this is, I think, part of the journey that I hope I've shared with you. All right, a systematic approach in which you look at something across the continuum, and you know, you don't plan these things, but sometimes they happen, right? And so it's exciting to see this work happen. But also keep in mind that this is used multiple different ways, from correlative studies to cohort studies to clinical trials, policy pieces, editorials, working with advocacy groups, working with others in the task force to make this happen. And I was sort of playing around with this, and I said there are two pathways to excellence. I'm thinking about U.S. News and World Report, right? So it either can skim from the top, right, which is called cherry picking. You don't want to hear the opposite word of that. It's called lemon dropping. I'll put it there. Or you can address the inequities. The argument I make is that, and which is, I'm convinced is true, that you can achieve excellence, but to do so without excluding people means you have to address those structural barriers and have systems in place that address those structural barriers. But this is the definition of health equity, right? But healthcare equity means that we have to provide the highest quality of care without excluding anybody, but also addressing the conditions that made people sick or sicker in the first place. That's called community engagement and community investing in social determinants of health support, or addressing structural barriers. Your being here is addressing the needs of people around this area. So imagine if this did not exist, what will happen? So let's leave no one behind. That's actually UN socially sustainable development program. So, but addressing health equity saves lives. It will support key performance indicators. And I'm convinced that done right will help increase our reputation. And this is one that my wife picked out. When we visit England, any of you have been to England, say, mind the gap, but stay calm, right? Again, I want to emphasize, I've come to the conclusion that systems first. Let's get a house in order. Let's not get people to places where they are sort of blind alleys, because it creates distrust, reinforces distrust in the health system. I won't bore you with this. This is a study in which we should get funded to do. And I'll leave this up for a little while, actually, after I show you some of my buddies. And you got to have a village to do this. These are some of the colleagues. Joanne to the right used to run the program in Southern California. Oh, yeah, this one. So TR to the left runs the one in Northern California. We're actually on a call together 2 days ago, planning. Noah Weiss is the father of case control studies. Bob Fletcher and his wife were sort of my mentors. Doug Corley and I, we've been at the hip together for the last 15 years, the gastroenterologist. He was the editor-in-chief at Gastro when I was there. But I leave this up as I close with just a few minutes left for questions. But we want to dive a little bit deeper to understand, if you look back at that New England Journal paper, why were those gaps there, right? Between Black and white people when the screening rates look similar. It didn't make sense. Our hypothesis is that, despite the rates looking similar, downstream care was different. And what made it close? What are lessons there from there? In the usual way we do these things, we will partner with Miscan Model in Erasmus Medical Center in Netherlands. So do some modeling around some of the areas in which the opportunities to scale interventions. So again, thank you for having me.
All right, who has questions? We will ask you to speak into the mic so that those on Zoom can hear as well. And for those of you on Zoom, I'm monitoring the chat, so feel free to type them in.
Hi, I had a two-part question for you. Would you mind just telling us why you first got into looking at Kaiser as a health system for this and not like your system, Ohio State? And then have you ever thought about looking at uninsured populations and tracking their screening?
Oh, we've done the latter. We actually did a lot of the uninsured population using Medicare data. And there's actually a paper that I like a lot. We published a few papers using Medicare current beneficiary survey, but also papers using NHIS, National Health Interviews Survey, which has information insurance. The other place where we looked at this was the NIH AARP study, which was retired persons. It's not so much of on insurance, but the type of insurance. And what we actually found, if I remember correctly, is that there was almost a 5-year lag in the screening rate between Medicaid, people receiving Medicaid, or people who don't have supplemental insurance, and those who have supplemental insurance. So why Kaiser Permanente? I'm actually glad that I stumbled on this collaboration. Kaiser Permanente provides insurance as well as care for a defined population. Epidemiologic studies are really hard to do and do well if you don't have a defined denominator. In other words, if you're doing a study and you want to say this is a rate of something, you have to have an unbiased population that's not selected for one reason or the other to be able to make firm conclusions. And the fact that you can actually follow people over many years, so those studies to look at it, I didn't show you all of the numbers. Some of the people have been enrolled in the program for over 20 years. That gives the ability to attract people over time because they have a stable membership base, attract people over time to see what's happening to them over time. That is almost impossible to do except maybe in the VA system elsewhere. Because in private insurance, people jump up and down, you get Medicare today, then get this insurance today, the benefits change and all of that. There's no certainty that the benefits remain the same. The other piece around Kaiser is that Kaiser does have a large number of people who have Medicaid, even Medicare. So we're able to look at insurance as if we need to do so.
Thank you for the good presentation. I have one question. In your report, in your study, you emphasize a lot of systems thinking and particularly policy. This is a distal kind of approach that gives you very good results. But my question is, how would you use this study and several other studies of this standard, of this context, to influence politicians to be able to take these policies so that these disparities can actually be addressed, because politicians are quite complex and difficult to deal with? Thank you.
Well, that's sure is a very difficult question, very important question, but difficult to answer. But I'll tell you what we did. In the case of colorectal cancer, we were fortunate that there was an advocacy movement in place. And that was the National Colorectal Cancer Roundtable. The American Cancer Society deserves a lot of credit for much of what we've done. We also had the trade groups like the American Gastroenterological Association and others around there, Prevent Cancer Foundation, for instance, who were ready and there to support the work. And the part of the benefit that we developed as a group, there's always been a colon cancer group that comes together at a meeting called the DDW, Digestive Disease Week. It's an international meeting, probably the biggest meeting for GI specialty for students. Is that we will every year come together to update each other about the work we do and the progress we've made. And then we'll tend to gather again in the colorectal cancer roundtables to talk about the work that we've done. And all with the eye that there were some of these things that were preventing coverage for the people who needed it the most. I haven't done it, but many in these network, there are now networks, there's one group I've actually have a meeting in California now, will go to Congress to lobby. And that lobby effort persisted. Many worked very closely with CMS because some of the barrier was with the fact that Medicare had this partial coverage, and private insurers will tend to follow what Medicare does, even if they are required to do something different. If the government does this, why should we do X? And because we were working in those networks, when questions came up and said, oh, we're not doing it because of X, then we went back, looked at the data, or did studies to inform that gap that policymakers identified for us. And I think the compelling thing that you see in that trajectory of things that presented, work we did, others did, clearly demonstrated that full-on colonoscopy, if they didn't believe it, is part of the screening process, right? And the silliness of the idea that when you find a polyp and it's biopsied, all of a sudden someone has to have a co-payment, so-called surprise billing. So you wake up after being told you're getting a free test, only to find out, oh, you had a polyp. Oh, by the way, you have a co-insurance, and that could vary depending on where you are. If it's $1,000, now you have, something 20% of that to pay, $200. So imagine someone who is food insecure. And when you know that, what are you going to do? Put food on the table or get a colonoscopy done for something you don't know if it's even bothering you, right? At this point. So I think I think it's important. And when we do our research, it's really important to see where are the other connections to the work that we need to have in place. If nothing else, inform what you're doing. But what I think is more important is that how do you use the research to inform change? At a level, you also want to develop a credibility, right? Repetition. I can tell you that I'm very anal. You probably don't want to work for me. I'm very anal about making sure data are accurate, because if you slip up once in the source of repetition, it's much harder to stand up again and have people believe in the credibility of what you do. So I think all of those are important. But the one thing I would encourage all of you is that research can be hard. but it can be highly rewarding. What's also important is that you need to have a mentor who is working with you, right? And the other piece is try to think about research as a process. You may have a very strong conviction about something, but sometimes what I've done is I can get this funded. I need to do this, and I get this funding to help me do this as well as that. Because this might be harder to get funded, but that changes over time, right? So, great question.
Any other questions? Well, if not, there's one comment in the chat, and I think Dr. Cynthia Morrow speaks for all of us when she says, "Thank you for covering such an important topic with great new information. We appreciate the attention to practical implications." Thank you very much.
Thank you, Cynthia.